Whoops, sorry for the delay. For some reason, my camera is not working. There we go. Well, good afternoon, everybody. Thanks so much for joining us. My name is Greg Olson. I'm the director of the New York State Office for Aging. Hope you all had a great holiday and wishing you a healthy and prosperous 2023. So happy New Year to you all. I'm really excited about our dialogue today. I have three incredible experts and champions in terms of all of our overall health and wellness. So the three topics we're going to talk about today are some of the really good things that were passed in the bipartisan, what's called the IRA, which is the Inflation Reduction Act, which was passed in the fall. We're going to talk a little bit about COVID and, of course, the flu. Our primary job here today is not only to walk you through some of those good things that are going to benefit you and your families, but also to try to keep you safe. We are not out of this pandemic, unfortunately. There's still steps I think we all need to take, and there's a lot of misinformation out there. So what we're designed to do today is really cut through the misinformation and get right to the facts. So let me introduce these three amazing people that I have with me today. I'm going to start with Dr. Dara Kass. She's a graduate of SUNY Downstate College of Medicine and the Kings County Hospital Emergency Medicine Residency. She began her career in resident education at the Staten Island University Hospital, followed by medical student education at New York University School of Medicine, and most recently was an associate professor of emergency medicine at the Columbia University School of Medicine. She's a champion for gender equity and the advancement of women in medicine. Dr. Kass's academic work is focused on creating a more equitable workplace for women in medicine. And most recently, she shifted her focus to policy and public communication in regards to the COVID pandemic. She works for HHS in Region 2, which covers New York, New Jersey, the U.S. territories, the Caribbean, and several federally recognized tribal nations. So welcome, Dr. Kass. Next is Rhonda Schwartz. She has served as the regional administrator for the Administration for Community Living, ACL, at the U.S. Department of Health and Human Services since 2019 and currently acts as the regional administrator for Region 2, which includes New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands. As the regional administrator, Rhonda is the representative for the ACL administrator and the assistant secretary for aging at the regional level. She oversees what the New York State Office for Aging does. Rhonda joined ACL in July of 2016 as an aging service program specialist in ACL's Region 1 office located in Boston, Massachusetts. In that capacity, she worked with federal, state, and tribal organizations with particular attention to oversight of the Older Americans Act, state and tribal grant programs. Prior to joining ACL, she spent several years managing Older Americans Act and other ACL programs at a state unit on aging. She earned her BS in Business Administration from Georgetown University in 1985 and a JD from Columbia University in 1988. So welcome, Rhonda. And last but not least, Dr. April Smith-Herack. She is the Regional Health Administrator for Region 2. As the RHA for the Office of the Assistant Secretary of Health in the U.S. Department of Health and Human Services, Dr. Smith-Herack is responsible for public health leadership across the region and assists in policy delivery in several areas, including COVID-19, health equity, opioids, and chronic and infectious disease prevention. She's dedicated to federal public health work since 2004 and has worked with Region 2 since 2010. Prior to that, she worked with the Centers for Disease Control and Prevention in Atlanta, where she worked to address a broad range of public health areas, including policy and regulatory work in infectious diseases, nutrition, physical activity, diabetes education, emergency preparedness and response, and much, much more. She has a PhD in psychology from Yale University. So April, welcome to you as well. So let's talk just briefly contextually. We're going to start with the Inflation Reduction Act. And for those that don't know, a lot of things happen at the federal level and the state level, big packages of legislation that have a lot of things in it. And oftentimes the general public doesn't know what are in all of these really large, whether they be omnibus packages or what have you. And we're going to try to do a little a deep dive in that. But what the Inflation Reduction Act really does which I think is going to be most relevant to you guys today, is lower prescription drug costs, which has been an ongoing topic for decades and decades. But it also lowers healthcare costs, will lower energy costs, and it's the most aggressive action on tackling the climate crisis in American history, which will lift up American workers, create good paying jobs, but also address the environment, air quality, other things that have a positive impact on all of our health and wellness in the short and the long term. So, Dara, let me start with you. How many Americans do you guys estimate are going to benefit from the Inflation Reduction Act drug pricing savings? Because I think this is something people are really, really excited about.
I mean, I think that they're excited because it's exciting. I mean, it's millions and millions of Americans, right? Between 5 and 7 million Americans who are beneficiaries of Medicare will see some element of their drug pricing go down, which is, for everybody out there who spends, every day thinking about how they're going to afford their medications and what does it mean when you get a new medication prescribed to you. This is where the rubber meets the road, and where we know that patients that are on Medicare beneficiaries are going to be able to do things like cap insulin costs, which we'll talk about, or have out-of-pocket costs being capped, or allow the federal government to negotiate drug prices for the most expensive medications out there. There's a lot about drug pricing in this bill that will really affect people's day-to-day lives, which we can't always say for packages like this when they pass.
Yeah, you're absolutely right. I mean, this is music to people's ears. We've been looking at, and you hear the stories like, you mentioned insulin. There's so many other drugs where, the monthly cost or the annual cost, rivals that of a brand new automobile. I mean, it's out of control. And, for the population that we serve through our office in New York, most of the clients that we serve have, more than 4 chronic conditions and take anywhere from 6 to 12 prescriptions. So you're spot on in terms of the timeliness of this issue. Are the savings that you're talking about from the IRA going to be significant?
They are. And I think that there are going to be savings in different areas for different people. But overall, you're talking about thousands of medications that have gone up in cost over time. And part of the Inflation Reduction Act, part of this was actually that there would be inflation adjusted metrics for the increase in drug pricing. So not only will you see a cap in things like insulin, not only will you see a cap in out-of-pocket costs, but pharmaceutical manufacturers are not allowed to increase the price of their drugs greater than the price of inflation, which could affect a lot of people's everyday out-of-pocket costs on top of those maximum out-of-pocket benefits. So I think it's really, really important to realize that even if you don't take insulin, right? Even if you're not spending thousands of dollars a year, there will still be, over the next few years, material impacts in your daily drug costs if you're taking even 1 or 2 medications.
Yeah, and I mean, and it's common sense that if you can't afford or don't have access to the medications you're prescribed for whatever, there's a negative impact to that. And we know one of the top reasons for preventable hospital readmissions is around medication and medication reconciliation. So, I think what a lot of folks don't know when they work, in the industries that we do is things pass, but it doesn't mean the next day they go into effect, right? It never happens that way. So, can you walk us through what are some of the dates that the cost reductions or caps will be in place for things like insulin, drugs, vaccines, things like that?
So that's what's amazing about this legislation. Actually, there was some next day impacts, more or less. I mean, it passed last year, and January 1st was the day it started, but it's really already passed. So right now, as of January 1st of 2023, there is a cap on each prescription of insulin that you are prescribed per month. So meaning that if you're on 1 prescription of insulin a month, it's $35 out of pocket. If you are on 2, it would be $70. But that has already gone into effect. The same thing is true for the out-of-pocket costs on vaccines. So any vaccine that's recommended by the ACIP, which includes things like the shingles vaccine, which is really, really relevant to this community. We can't decrease the side effects of the shingles vaccine, unfortunately, but we can decrease the out-of-pocket costs. So as long as a vaccine is recommended by ACIP, it will be cost-free to a Medicare beneficiary. Then over the next few years, so starting in 2023, 2024, you're going to start to see the $2,000 out-of-pocket costs come in. the limitation. Then you'll start to see the drug pricings be negotiated. They're going to start with 10 drugs, and then they're going to increase over every year. They're going to increase the number of drugs that they're negotiating based on, utility costs, out-of-pocket costs, and other things that Medicare itself will determine. We don't yet know, which is a really important question, which drugs will be negotiated, but we will know them over the next couple of years and be able to share that as soon as we do know it.
So, to that point, right, as things start to evolve and more prescriptions, fall into the categories of what you're talking about, how would a general person in the community, where would you tell them that they should look or track as these things start to roll out so that they can match potentially prescriptions that they might be prescribed to the reductions that you're talking about?
So I think that these kind of Facebook Lives are really important for that. So being plugged into the Office for the Aging, being plugged into us at HHS, whether it's, through ACL, where Rhonda will talk about, we really try to do a really good job. CMS, the Center for Medicare and Medicaid Services, really tries to communicate that every time there's a change, but also going to your doctor and saying, do you know if there's been any updates on medication? Could I be eligible for one of the medications? Some of this may be communication with a physician to say, am I eligible for one of the medications that has been capped as opposed to what I'm on already? So some of it's a little bit of patient advocacy on ourselves. Some of it is just staying plugged in. And then it is on us as, leaders in the federal and state government to reach out to communities to make sure that you understand what's going on.
Yeah, I think that's a really important point, that physicians are going to be learning at the same time we all are. So I'm going to put you all on the spot. And as things change, you need to come back and we'll do this again and again and again until we get to where we need to be. I'm going to shift gears a little, Dara, and just, if you could kind of go over what some of the impact of the Inflation Reduction Act will be on making access to healthcare more affordable.
So actually, this is a really remarkable thing across the board, not just for Medicare beneficiaries, but 13 million Americans will save an average of $800 a year on health insurance premiums. And 3 million more people will have insurance than before this law. So there are real benefits to the general population on the access to health insurance and keeping premiums down, which we know is important across the board for healthcare access.
Yeah, that's great. I know here in New York, Governor Hochul has proposed really, tamping down on, going after individuals with medical debt and others. So you couple some of these things together, it could be really beneficial, not only for the pocketbook, but for the stress and strain that some of those things, relate to. I'm going to go back to vaccines. One last question, Dara. Are there some vaccines that are free now? So I did receive, my shingles vaccine. I had a couple hours of downtime, but not much of an issue. None with the first shot, a little bit with the second. But in addition to that, are there other vaccines that folks can get now free of charge?
So every vaccine that's covered by the ACIP recommendations is free of charge right now, which is a really big deal. We know, like I said, can't do anything about the side effects, but we can really make sure that people know that, we've seen the uptake with the COVID vaccine, and we, of course, encourage everyone to stay up to date with the vaccine. We'll talk about that in a little bit. But that when vaccines are free to the consumer, they're more likely to take them. And we know that this is a public health mandate. It's something that's really important to us at the federal government. So we're going to do everything we can to make sure that vaccines that prevent illness and prepare you for an unfortunate infection will be free to you as best as we can.
Great, thank you. I'm going to shift gears now and bring Rhonda and April into this. I know that people are tired of COVID. We all are, but that doesn't mean it's not still real. That doesn't mean that we're not spiking again. In New York State, since January 1, 560 people have died. If that trend continues at 40 a day, and I get updates from the governor every single day, that will be another 14,000 people just in New York that have died. And we've already had 80,000. That doesn't mean the individuals that have been in the hospital, that have been intubated, that may, develop long-term COVID. Look, we're all tired of it, but you can't put your head in the sand and pretend it doesn't exist, because it does. So let's start with you, Rhonda.
Sure.
In your role at ACL, How is increasing access to the vaccines part of ACL's larger mission to ensure that older adults and people with disabilities of all ages can live healthy and full lives in their communities?
Well, you know, Greg, staying free from serious illness obviously is a critical part of staying healthy and independent, which is part of our mission for older people and people with disabilities. And staying up to date on your vaccinations is the most important thing that we all can do to protect ourselves from serious illness due to COVID-19 and due to flu. You know, we're in the height of winter. People are inside. They're not outside getting fresh air. We're in small confined spaces with each other. It's really crucial, especially for older people and people who have disabilities, who face the greatest risks, that we all are up to date on our vaccines. And also those folks who have underlying health conditions of any age, they're also at greater risk for serious illness from COVID-19. You know, we not only want to protect ourselves, but we need to think about those around us, our loved ones, our families, and others around us. It's just really important that we all work together to try to help protect each other from serious illness due to COVID-19. I know people are, as you said, they have fatigue from it, and we're tired of hearing about it, but it's not going away. And it's really, really a crucial time now that we're in the middle of winter.
It really is. And there's a new variant, right? Seems like every few months, you know, you're reading about a new variant. Certainly here in the Northeast, most of the cases are this new variant. I don't get it. I really don't. You know, talked about the side effects of the shingles vaccine. Well, it's maybe or maybe not a small side effect, but the value of it in terms of the side effect, they don't even compare. And it's the same with the COVID vaccines. It's like, you know, I know there's a lot of misinformation out there, which is why it's so important to have folks like you guys on. And we spread the message all the time. It seemed like in the beginning, especially for older adults, the demand for the vaccine was extraordinarily high. And then you see the numbers, you know, over a 6-month, 12-month, 18-month, 20-month, 24-month period, and they're going down. And it's not just for the older population. So I'm just not sure you know, why there's apathy in, you know, protecting your own health, saving your own life, and to your point, those that that you love and that you're around, that you wouldn't take those precautions to not infect somebody else. What is ACL doing to make sure older adults have access to the vaccines, not only now, but in the coming months? And if you could you address the dollars that just went out to NCOA and other national groups that there's rolling applications out as we speak that community organizations, county governments, et cetera, can apply for to get those vaccines into people's arms?
Absolutely. Yeah, this is a huge concern for ACL. As you mentioned, the percentage of older adults who receive the primary course of the vaccine is extremely high. That was excellent. But of course, that's really been waning over time. And I don't know if folks misunderstand the value of the vaccine or what the vaccine is intended to do. It's not intended to completely prevent you from getting sick. But if you, just like the flu vaccine, if you do get sick, your chances of becoming seriously ill are going to be much lower. And so too few people with disabilities and older adults have gotten the updated vaccine, as you mentioned, Greg. It's the bivalent booster that both boosts your immunity and better protects you against disease caused by the Omicron variant, as well as the original virus, and it's putting people at increased risk, particularly as that we're gathering indoors during winter, as I mentioned earlier. You know, nationally, only 39% of people 65 and older have received the updated bivalent booster. And in New York, I think the figure is even slightly lower than that. And I came across recently, which is something I think is interesting. There was a new study from Israel. It's not peer reviewed, but it just came out of Israel. And it has showed there's more than an 80% fewer hospitalizations among people 65 and older who had received, I think it was the Pfizer version of the bivalent booster, compared to those who had at least 2 doses of vaccine, but no bivalent booster. That's a huge difference. Huge difference. So what is ACL doing? We're very concerned about this. It's wintertime. We've got to get people vaccinated. So you alluded to this new initiative we've got going. So let me tell you a bit about that. So in December, the Administration for Community Living awarded 2 grants totaling $125 million. And the purpose is to rapidly increase the number of older people and people with disabilities who get the updated COVID vaccine and the annual flu vaccine. We're looking at both of those. The programs are going to distribute funding and leverage partnerships across the aging and disability networks to host community vaccine clinics, provide in-home vaccinations, transportation to vaccine sites, conducting outreach and education to older adults and people with disabilities, and more. So funding has started to roll out, as you mentioned, and folks may have seen the 2 grantees are starting to advertise for the ability for folks to apply for funding. So there's 2 different grantees that we awarded these funds to, 2 national entities, because we're thinking this is the quickest, fastest way to get that money out there and on the street. So the first is US Aging was awarded $75 million to establish and leverage partnerships and engagement with centers for independent living, area agencies on aging, state no wrong door systems, aging and disability resource centers, and other ACL-funded networks and other community-based organizations that serve older adults and people with disabilities. And then in addition, the National Council on Aging was awarded $50 million to build and leverage partnerships with senior centers, community centers, and local community and faith-based organizations that reach older adults and people with disabilities. And some of you may have seen NCOA has been posting advertising for applications for its grants that it's going to award. Now, both of these programs are going to prioritize reaching older adults and people with disabilities who have been historically underserved and who face additional barriers to accessing vaccines, including but not limited to people who are from communities of color, LGBTQ plus communities, Native American, folks at risk of institutionalization, people of low income or limited English proficiency, and people who live in rural areas. So again, these 2 programs are going to award sub-grants to fund vaccination programs in communities on a rolling basis. And so be on the lookout for information about these grants. And that's what ACL is doing. I'm excited about that initiative. It's really important.
I am too, Rhonda. I'm going to ask Roger now if you can put US Aging and NCOA's website into the chat. Just some of the things you talked about, senior centers, congregate sites. We have 834. We've got 59 county offices for the aging. We have over 5,000 faith-based organizations, just to name a few. We oversee the ADRC. We work with the ILCs and independent living across the state. So there's an opportunity for those of you who are listening at the local level to go and apply. Now, if you've ever applied for a federal grant, it's not always the easiest thing to do, but I think, I want to build upon what Rhonda said, and they've made it extraordinarily easy. The reporting requirements are not excessive. Sometimes you get mired in the paperwork and the administration of these things, and it takes time, but they have very, very much simplified this to make sure that those vaccines get to where they need to be and ultimately in the arms of folks. So April, Rhonda talked about the study from Israel, and it's a great segue, because I was going to ask you, do the vaccines work, right? And do I need a booster? So what's the answer to that? Because it seems pretty clear to me.
Yes, Greg, the vaccines do work. And as Dara mentioned, it may not completely prevent you from getting COVID, but what happens is if you are exposed to COVID and you do indeed get COVID, your chances of having those severe outcomes where you end up in the hospital and unfortunately some people do ultimately die, those chances and that risk goes down really significantly. And so the vaccine is really intended to prevent the most severe aspects of the disease. Now, I think you had been asking a little bit about why do we think that people have this fatigue? Why do we think that our rates are so low? And frankly, our vaccines have done such a good job, and especially here in New York, we saw such uptake in the primary series of the booster before the boosters that we did see a lot of people getting COVID and a lot of people saying, oh, it's just like a cold and I was fine. And what people don't often realize is that might have been or probably was because you were vaccinated and the vaccine was able to help your body fight off the more severe effects of COVID. Now, what happens over time is that our immune systems don't always have the same response as when they've just been introduced to a virus initially. And so that initial exposure, whether it was a natural COVID infection or whether it was, a vaccination, over time, our bodies don't remember as well how to fight off the disease. And so that's why we do need these boosters. It's a combination of that fatigue happening, and then also really seeing that these boosters and the vaccines do work. And sometimes we just feel like, oh man, I just got that booster. Why do I need another booster? And the reason is sometimes our immune response needs a little memory tickler. It makes it sound very light and glib, but really it could be the difference between saving your life and having a very, very severe outcome. Versus, something that is experienced more like a cold. And that is what we want to see if people do get COVID when they're exposed. So the answer is yes, you should get a booster. If you were boosted before September, then you probably had the monovalent booster. So this would be a good time for you to be thinking about the bivalent booster. Monovalent, bivalent are really big words. All it means is whether there's one strain of the virus or two strains of the virus. And this bivalent updated booster is something that gives you protection against the Omicron. And you mentioned a lot of new strains circulating. Most of these new strains are variants and derivatives of the Omicron lineage. And so that bivalent updated booster is going to give you better protection if you are exposed to COVID. And as we know, COVID is still a very real thing. Like you said, it is still circulating. It doesn't have the seasonality that we had initially thought that it might have. We have seen increased COVID circulation in the winter. We've seen increased COVID circulation sometimes in the summer. And so having that booster, no matter what time of the year it is really important, especially for older adults who are more likely to experience these really negative outcomes from COVID.
And I'm glad you raised that September date. So interesting, and I'll use myself as an example because this actually happened. I had my routine physical on September 1. I'd asked my doctor if I should get my booster at that time. They were the new variant, or the new booster hadn't come out yet. So I got my flu shot and the booster on September 1. And then of course, 5 days later, the new booster came out. So should I go back now and get that new booster? Because the last one that I had was the old, not that it's ineffective, but the older booster.
Yeah, and you're still deriving some benefit from that older booster that you got in September. We do know that immunity wanes over time. It doesn't just disappear altogether. But to have the maximum amount of protection, you would be recommended to go and get the bivalent booster. You've had enough time lapse in between the two shots, and you shouldn't worry about it, which is why we say anybody who did get vaccinated back in September, before September, before the bivalent booster came out, it's really a good idea to think about going and getting your second booster shot. That would be recommended by CDC.
I will do that. So, one of the things, April, we hear all the time, and, I think the previous administration really did a disservice to a lot of Americans, talking about herd immunity, talking about, the efficacy of vaccines, that you really don't need to take them. And you hear this all the time. Well, why should I get a vaccine if I'm going to get it anyway? Shouldn't I allow my own immune system to to fight it off? What do you say to people like that?
Well, what I say to people is, do you like to gamble? I'm not sure that I would adopt that attitude. I understand why people would think that. But what I can say is that the side effects that you might experience from getting a COVID vaccine are really pale in comparison to having a very severe case of COVID. And the thing that we know is that when people get COVID vaccine and get the COVID vaccine boosters, we know that there are some side effects. Sometimes maybe you don't feel great for, like half a day, maybe you feel a little tired, maybe your arm's sore. But that really pales in comparison to the chances that you could get actual COVID from a natural exposure and become very, very ill. People don't generally become that ill to the vaccine. And so what you're really doing, if you're choosing to go the natural immunity route, you might have a very mild case of COVID, and that's totally possible. But it's also very possible that you could have a really severe reaction. We also know that COVID vaccination can help prevent some of the effects that are happening with long COVID. And so even if you had a mild case, people with mild cases sometimes end up with long COVID symptoms. So if there's any chance that you might be able to reduce that, then I would also consider that a benefit to going the route of vaccination. Some people have, Greg, I'm guessing your next question might be, what if I already had COVID? Yeah.
That was my next question.
Here in New York, we like to lead the nation in all things, right? So we're great at that. And unfortunately, we were also really, really great at leading the nation in COVID as the pandemic began. And many people got COVID even at the beginning of the pandemic before there was any ability for a vaccine to prevent our illnesses. So, I'm one of those people. I'll just share with everyone, I did have COVID and I was vaccinated after I had COVID. And then even being vaccinated during the Omicron wave, I got COVID again. I can tell you the difference between having COVID unvaccinated and having COVID vaccinated is drastic. It really was much more of, a 4 or 5 day bad cold for me after I was vaccinated. So then when the bivalent booster came up, the question was, well, do I get the bivalent booster? And the answer is yes, because I want that protection again next time. So some doctors may recommend that you wait 3 months to get your booster after you've had a natural infection. You can wait that long if that's what's recommended by your doctor. But I wouldn't forgo the booster altogether, because just like with immunization, natural infection immunity does wane over time. So that protection that you're getting from that infection is not going to last also.
Okay, so the answer is, if I already had COVID and recovered, do I still need a vaccine? The answer is yes. And I had a similar experience. I was COVID free for almost 2 years, took it very seriously. And then, trying to get back to work, flew 2 places to do a couple of conference speeches. And of course, I came home with COVID, but still getting the boosters, and we'll continue to do that. Rhonda, am I still considered fully vaccinated if I don't get a booster? And what does up to date mean? Does that include the booster?
Yes, some of this terminology, am I on? I'm not on mute. Good. Some of this terminology gets very confusing, as you were pointing out earlier, Greg and April. So you are considered fully vaccinated if you got the primary course of the vaccine. So that would be two vaccine doses for Pfizer and Moderna, and then it was 1 dose for Johnson & Johnson. But the definition of fully vaccinated does not include a booster. So you're up to date on your vaccines if you've taken the most recent booster that's recommended for you. So you're fully vaccinated if you got the full original course of the vaccine, and then you're up to date as long as you've gotten the most recent booster that is recommended for you. And before we go on, Greg, I do want to just go back to something April was mentioning that I think folks forget, and it's an important benefit of the vaccine that I think folks don't talk about enough, which is there does seem to be, and correct me if I'm wrong, April, some evidence that it may help reduce your chance of getting long COVID when you do get COVID. And that's an important thing, I think, to consider, because long COVID is no joke, and it's not pleasant for folks who have to deal with that. And my understanding is that even folks who get mild cases of COVID can end up with long COVID. Is that correct, April?
Yes, and the research is not completely in yet, but the early indications are that the vaccine may help to avoid some of those long COVID symptoms as well.
So that's another reason to get your booster.
Definitely. And Rhonda, speaking of boosters and vaccines, where can people go to get them? I tell you, I drive all over, and it seems like the signs out in front of pharmacies and Walmart, and obviously your physicians. So it's super easy now versus when the vaccines first came out to get them. What would you recommend? Where would you recommend people go in their communities? So
certainly, if you are able to get yourself to the pharmacy pretty easily, or get to your doctor's office, you certainly could call your doctor's office, see if you can go there to get a booster. You could contact your pharmacy, see if you can make an appointment. Many of them are making appointments for folks to go in, so it's very easy. if you have, if that's not the route you want to go, there are other places you can contact to get information on where you can go to get a vaccine and how you can get assistance if you need transportation and things like that. Because in lots of communities, they have a lot of programs going on where you can get help getting transportation to a vaccine site. You may be able in some communities to have an in-home vaccine. So there are a few places you can contact, and I think we're going to put them in the chat here for folks, but there's the Elder Care Locator, which is a service of the Administration for Community Living, and that's a place you can contact for vaccine information for older adults. And again, this is throughout the country, so you can contact the Elder Care Locator. Also, we have the Disability Information and Access Line, also operated by the Administration for Community Living, or I should say funded by the Administration for Community Living. And that's a place where folks with disabilities can go to get information on where they can go to get vaccines. And then you can also go to vaccines.gov to find COVID-19 vaccine locations near you. So again, if you have trouble getting access to vaccines, please go to any of these places to get more information. And I'm hoping that as these new grants that I talked about earlier roll out in local communities, Greg, that we're going to see more and more initiatives going on relating to helping people with transportation and maybe more in-home vaccine services and things like that. We'll see what we're able to provide.
Yeah, and I agree. I was going to tie that together. So I'm glad that you did. Those grants are available for communities that are interested in kind of beefing up getting shots in arms. And if you're here in New York State, you can call your local county office for aging, your local public health department, and they can assist you as well. So let's shift gears here for a minute and talk about, our annual talk regarding the flu. That changes every year also. So April, what's the current status of the flu? Nationwide, New York State, where are we?
So nationwide, we have seen a very early and very pronounced influenza A spike across the country. We saw very early widespread activity throughout the US. New York, as our leadership position dictates, led in that spike. And we really started seeing activity almost as soon as the reporting began for the season. The influenza vaccine strains or the influenza strains that are circulating right now are very well matched to the vaccine. So even though we saw this early A spike, what we're seeing now is that the rates of influenza A transmission have gone down, but there are two different influenzas that generally circulate in a season. We have influenza A, and usually there's a couple of strains of those. And then we have influenza B strains, and there's usually a couple of strains of those. What we saw in the Southern Hemisphere, which is usually a good indication of what we'll see in the Northern Hemisphere. So this flu season, the Southern Hemisphere saw an early and pronounced A spike, and then that was followed by an increase in influenza B circulation. So right now we're just about through, hopefully, knock on wood, with our A spike. It doesn't mean that influenza A won't be circulating for the rest of the season, but it does mean that we won't probably have as much widespread transmission of influenza A, but we do expect to begin seeing more influenza B transmission over the rest of the season.
So would it be safe to say, because most people, right, the direction is get your flu shot October-ish, right? We're in mid-January. So your advice is if you haven't gotten your flu shot, get your flu shot. The still flu season is out there.
It's not too late. And if you had the flu already, it's still not too late to get a flu shot, because in all likelihood, if you've already had the flu, what you had was influenza A. And if we know that there's a really high likelihood that most of what's circulating and what you're most at risk for the rest of the season is influenza B, having that shot contains both influenza A and influenza B strains. So you'll have protection against those influenza B strains for the rest of the season. So it's definitely still worth getting a shot if you want.
And it's important for all the populations, but can you talk a little bit about why it's really important for older adults to get the flu shot?
Absolutely. Well, we know that older adults are at increased risk for adverse effects of a lot of different medical and infectious diseases. But what we also know is that as we get older, our immune system just doesn't function as well as it used to. And so like our immune memory wanes. So for those who are over the age of 65, we really especially recommend getting an influenza shot, because your immune system needs that tickler for their memory. The strains do change every year, and our immunity does wane from last year. So last year's shot is not really protecting you anymore at this point. And being over 65 puts you at much higher risk for severe complications of the flu, in much the same way that it does with COVID. And so many of the deaths that we see in an influenza season are in the very young, and also in those over 65. So it's very important for anyone over 65 to really consider getting that flu shot.
So I'm going to ask you guys one more question. And anybody can answer. I didn't give you a heads up on this, so sorry to throw you a curveball, but you're all experts. So we know about COVID, know about the flu, and in the news has been something called RSV, right? Talked a lot about children getting it, but it's not unique to children. Let's talk a little bit about that and what people can do.
April, you want to take it or you want me to take it?
Oh no, you're the MD. Go for it.
Okay, so RSV is a very common virus. Respiratory syncytial virus, it stands for. It's not new to us. It's not an emerging virus at all. We're seeing an increase in RSV in communities specifically, and the place where it's most important is actually children under a year, really under 6 months. Those children who oftentimes are premature or have lung disease are at risk for RSV infection and unfortunately hospitalization. Now, the treatment for RSV is not exciting. There's no new medications. It's just oxygen, sometimes some steroids, and some support. We also were seeing adults and older adults get RSV as well, especially with things like flu or COVID, and really the double whammy of having more than one infection. But again, the treatment for RSV is oxygen, support, rest, and the prevention is very similar to prevention of COVID, right? It's wear a mask in groups, make sure that you're not around anyone that's sick. There is no vaccine for RSV. So if unfortunately you get RSV, you don't want to get it along with COVID or the flu, which again goes back to making sure that you're up to date on your flu vaccine and your COVID vaccine, so that if you were exposed to maybe a grandchild who has RSV and then you get exposed to COVID, and unfortunately you're going to get one or both infections, you are as prepared as possible to fight off those infections and not find yourself in the hospital with multiple respiratory infections.
Yeah, and I think the moral of the story is, your safety protocols that you just mentioned were exactly the same in March of 2020 when all this started. Wash your hands, wear a mask, disinfect, things like that. It's not going to guarantee you're not going to get any of these things. It's certainly going to help. And if you're sick, don't go to the soccer game or to a party or, around other people. Stay home.
But again, remember that the most important difference between now and March of 2020, there's really two differences. One, we understand what we're dealing with, and two, we have vaccines. Right. And so I think for us to really reiterate right now, the best preparation for an unexpected infection, or even to give you the most flexibility, is to be up to date with your vaccinations before you get infected. And then also, and this is really important, we didn't really talk about it that much, but if you are feeling unwell, test frequently, test early. And if you are positive for COVID specifically, but also the flu, call your doctor and find out if you're eligible for medication. The use of Paxlovid, the by-mouth antiviral medication that can be given early on after a COVID infection, saves lives. 100%.
Yeah, and on the testing front, there was more money provided for free test kits. I ordered mine. They were here in 3 days. So that's another option for folks if you can't afford the tests. Which aren't all that expensive, but maybe unaffordable for some. You can still get some for free.
You can go to, covidtest.gov or covid.gov, and we'll get you those free tests. And also, if you have private insurance covers 2 tests per person in your family per month, free to you, no outlaid costs. They bill your insurance directly.
Excellent. So we have a couple minutes left, Roger. I know we have some questions. I'm going to ask you to open up your line.
Sure thing. Just a couple questions. A couple of people were wondering about help for older adults who have Medicare when it comes to dental and eye care. Any comment on that or developments?
I'll take that one. What I would recommend is that those folks contact HICAP, which is New York's senior health insurance program, and they can speak to a counselor there and get information on what insurance might be available, dental and eye care coverage. A lot of Medicare Advantage plans might include that in their package. So I would definitely recommend reach out to HICAP.
But there was nothing in the Inflation Reduction Reduction Act to make those standard benefits under Medicare, whether it be fee for service. Medicare Advantage plans can offer many more. Other questions?
Yeah, there's a question. Someone said, I'm on disability. My doctor suggested that I get a shingles shot. Well, my insurance doesn't cover it, and I was told it would cost $400 to get it. So is there anything that changed now that for that person?
The Inflation Reduction Act.
Right.
I mean, that's exactly this is exactly the situation we're talking about, right? So it's somebody who had shingles who is being encouraged to get the vaccine, which we know is across the board encouraged. So this patient should get the vaccine, even though they've already had shingles. And this out-of-pocket cost would no longer apply. That is $400 back in somebody's pocket that they do not have to outlay in order to get that vaccine. This is exactly the circumstance we're talking about.
And Dara, was that one of the immediate things that went into effect? So that should be now.
That should be now, January 1st, 2023.
Thank you.
The other vaccine that's really important for lots of people they don't think about is Tdap, which is the tetanus, diphtheria, and pertussis booster, which can cost you between $50 and $100. And oftentimes you don't think about it until you have a grandbaby. And then you're told that you need to be up to date on it because of the pertussis part of it, which can be very risky for children. So this is another advantage that people didn't think about until they're faced with see your grandbaby, and now you have to pay $50 for a vaccine, which we no longer have to pay.
Roger, other questions?
Well, while we're on shingles shots, I just had the shingles in November 2022. Someone asked, is it still important to get the shingles shot?
Again, I would speak to your doctor to find out the time frame, but it is recommended that people who've had shingles still get the shingles vaccine.
What if you didn't have shingles? So I got mine when I turned 50. I'm 54 now. Is that something that I get annually? Because I haven't had another one since I got the 2 shots.
So it's a 2-shot series, and that's it. You don't have to get it again.
Great. Thank you. Roger, we can do one more if we have one.
Okay, let's see. Let's do this one. I've been fully vaccinated and was boosted in April of 2022. Gotten COVID in November. Should I get boosted again now or wait a little longer because of the antibodies?
April, you want to do that one? Or you want me to do it?
Yeah, I'm pretty sure that the time frame that they're advising that you wait is up to 3 months. But when you hit that 3-month mark, I would go and get boosted. Dara, are there situations where the medical community might recommend earlier than 3 months to get boosted?
You're on mute.
I just realized, I was playing with it when so basically not really, especially not if you have been infected with the most recent variants, insofar as it is not necessarily helpful. So it's 3 months from recent infection or 2 months from recent vaccination if it wasn't the updated vaccine.
So this individual got their last booster in April of 22, so should absolutely get the booster.
Right, but then they had to be 3 months from their most recent infection, which they said was November. So
Gotcha.
I would actually put a calendar in, reminder in, and say, here's your 3 months. You then go on vaccines.gov, find out where there's a local vaccination available, and get yourself up to date.
Excellent. Well, this has been fantastic. As I said, I'm putting you guys on the spot when things change with the Inflation Reduction Act prescription or anything else that you think we need to get across. I'm counting on you to reach out to me. I want to thank Dr. Dara Kass, Dr. April Smith-Herak, and I can now say Counselor Rhonda Schwartz from ACL. As always, want to thank Roger Noyes, my communications director, for somehow making these flawless productions behind the scene. And please join us next week. We talked a little bit about money in your pockets. I heard money in your pockets, about that $400. We'll be joined by Fred Riccardi at the Medicare Rights Center and our own Heather Leddick, who is our HICAP state leader in our agency, to talk about the Medicare Savings Program, some additional eligibility because the cap was raised on individuals that are eligible for that can help put money back in your pocket to pay for co-pays, premiums, and deductibles. And our analysis in New York State is it would save people about $7,000 per year. So we'll be talking about that next week. Again, thanks to all my guests. Thanks to Roger. Thanks to you guys for tuning in today. And we'll see you next week.